Hi, good afternoon, everybody. My name is Tanya Chawla. I'm an abdominal radiologist at the University of Toronto, and I have a particular interest in body imaging, but with a subspecialty interest in gynecological imaging. And I'm here at this meeting to have a discussion on various topics around gynecology. So the question that was posed to me was with regards to pitfalls in gynecological imaging and how best to avoid them. So I don't think there's a straightforward answer to this question. And the way that I would break this down is much like any other subspecialty system. You need to have a very meticulous and rigorous approach when you are looking at patients in the gynecology setting. So to begin with, I think you would try and optimize all your patient factors. So making sure that you're using the best possible technique for whatever the process is that you're looking for. So for instance, if you're staging a gynecological cancer, MR may be your first best staging modality in some circumstances, for instance, cervical cancer. However, with endometrial cancer, you would traditionally start with a pelvic or transvaginal ultrasound. So try and give yourself the best possible shot at imaging the pathology. Now, there may be patient-related factors that make it difficult for you to do best practice. So if you have a patient who's large, or for instance, if they have fibroids, doing a transvaginal ultrasound may not be the best possible technique, and you may want to change your strategy to the next possible test. In terms of actually doing CT-based imaging, again, giving intravenous and oral contrast can help you greatly, and we've seen that in the setting of ovarian cancer when you're trying to look for low-volume peritoneal disease and you're trying to risk stratify the patient to try and triage them to either surgical or neoadjuvant treatment. You want to give yourself the best possible opportunity to try and stage the patient appropriately. So with regards to actually detection of findings, I can't give you a ABC of how to actually pick up the findings. What I would say is many of the pathologies that we now report have a lexicon-based approach, and they use a standardized template. So make sure that you are incorporating that into your daily practice so that you are checking off all of the areas of interest, but specifically honing in on areas where you might potentially miss pathology, and you're doing a rigorous search system by system to try and include everything in that lexicon that should be addressed for the particular pathology that you're looking at. And then certainly with regards to search of satisfaction, if you have found the primary abnormality, make sure that you're using all of the imaging sequences that you have, specifically using DWI, contrast-enhanced imaging, to try and risk triage appropriately. It's very easy to suddenly look at the T2s and the T1s and say, I know what this is, and not really go any further in terms of using that additional information that you have. So my overall approach is basically trying to get the best technical set of images that I can, optimizing the particular imaging modality to the pathology that I'm looking for, having an understanding of the disease process itself, how does it spread, what are the staging systems, and is there a synoptic report that allows me to hit all of the relevant information that my clinicians require to make an appropriate management decision. I hope that helps you avoid mistakes, and thanks very much for listening.
Don't forget to like, comment, share, and subscribe to OncoDaily on YouTube. Hit the bell icon to stay updated.